Thank you, everybody. I'm Dr. Deborah Renaud, a member of the Medical and Scientific Advisory Board of the ULF. And I was asked to try to give you a summary of the scientific symposium, which we held on Thursday. We had presenters from all over the world, as well as a poster session of 40 posters, many of which stayed up for you to view. I need to warn you that the presenters actually provided one slide each to summarize their half-hour talk, so I'll do my best to interpret some of them for you in English. No, just kidding. So our first speaker was Dr. Truus Abink from Amsterdam University Medical Center. And she provided an introduction on vanishing white matter disease and also talked about the integrated stress response and some therapeutic targets. Let me give you a little bit of background for those who aren't familiar with vanishing white matter disease. It's associated with mutations in the 5 subunits of E1F2B. And it has both a chronic phase where there's a progressive white matter abnormality and also acute episodic neurological events where you will have a decline associated with MRI changes that are distinct from the chronic white matter change, that are often precipitated by head injuries or febrile illnesses and infections and so on, sometimes extreme fright or excitement. And what they've learned, and what Dr. Abink's lab has learned, is that due to this reduced E1F2B activity, a number of stress-related genes are continuously being expressed in the vanishing white matter brain, even in the absence of stress. And what we know is that the more stress-related genes are being expressed on a chronic basis, the more advanced the disease state, and sometimes the more rapid the progression as well. And that suppression of stress-related genes improves the disease and slows the chronic progression. And so her laboratory has looked at something called guanabens and also E1F2B activators that try to turn on the E1F2B complex, which is deficient, to try to improve the activity of that complex. And these medications suppress the expression of these ISR-related genes, and they have seen some improvement in the clinical features of vanishing white matter disease using these medications. There currently are studies for both of these medications that are ongoing clinical studies in patients. We don't fully know how guanabens works, what that mechanism of action is, because the inhibition of this protein GAD34, which is targeted by this medication, clearly isn't the whole story, because the chronic disease is the only one that seems to be affected by this medication. And when it comes to the acute episodic neurological decline, other than trying to prevent fevers and illnesses and so on, there isn't a specific treatment. And so it's quite likely that 2 different medications may be needed to treat this condition. The next speaker was Dr. Mariana Bougiani. She's also at Amsterdam University Medical Center. And she's a neuropathologist there. And she provided a very comprehensive overview of the role of neuropathology, both historically when we didn't have other tools to look at leukodystrophies and how we learned what was some of the underlying causes of them, and currently with newer techniques and how neuropathology can contribute. One of those is an updated definition of leukodystrophy. You know, we often think of the names that we're familiar with, Alexander, Canavan, et cetera. But you also now hear terms like astrogliopathies or microgliopathies, and that's more of a definition based on, well, what cell type is the main one that's involved in that specific type of leukodystrophy. And sometimes when you cluster them that way, you can sort of see similarities in either pathogenesis or potential treatments. And so neuropathology has contributed to that. It has also helped with investigation of different cell types that may be involved, either by using cell cultures or what's called an organotopic brain slice, where you can actually use that as a tool to investigate the different cell types, as well as investigating the effects of treatment. So the role of neuropathology has really evolved over time into one that's helping us develop treatments. Dr. Shapora Falik Zakai from Galilee Medical Center in Israel was able to come to present her work in cerebrotendinous xanthomatosis. And there's a controversy because, of course, a woman, when she becomes pregnant, is already on treatment with CDCA for this condition to prevent the neurological decline. But the FDA and other organizations say that CDCA is a contraindicated medication in pregnancy, but it's listed actually by the FDA as X. An X category for pregnancy actually means there's no human data, so they're saying we don't think it's safe or we don't know. And so she did a very elegant study looking at this. The only data that was available before was actually in animals, so mice and in primates. And they used very high doses of CDCA, 4, 5, 10 times what you would ever use in a human. And they said that, well, this harmed the pregnant animals, and so we won't approve it to be used in pregnancy. But what we know, and in rodents, it can cause birth defects, but at very high doses. In primates, it causes some liver problems. But they think the reason for that is because, oops, I'm sorry, wrong, there we go, is that this substance gets produced that is hepatotoxic that humans are able to metabolize, but that primates and mice cannot. And so they did a study where they had 19 women with CTX who were already on treatment for CDCA. Some of them, they continued the CDCA, and what you can see is that the fetuses in this group had no complications, and the mothers were healthy throughout the pregnancy. But in the women who had the CDCA stopped, what they found was that the babies had intrauterine growth retardation. They were significantly smaller than expected. There was some intrauterine fetal deaths, so either miscarriages or stillborn infants. That when the babies were born, they often had more severe jaundice with elevated bilirubin. Their cholesterol, which is a biomarker of CTX, was elevated because it was coming through the placenta. So even though the baby wasn't affected, they were being affected by the high cholesterol because the drug had been withdrawn. And the mothers had neurological deterioration during pregnancy. So I think based on this information, this provides good support for the benefit of continuing the CDCA during the pregnancy, both for the health of the mother and for the baby. So I thought this was a very elegant study, so it was nice that she could travel to share that with us. Now this is a study from Dr. Joshua Bonkowski who, as you know, was the recipient of this year's Moser Service Award for his contributions to the ULF. And he presented on this gene ATAD1 as a potential rescue for Zellweger spectrum disorders. Now, these are also known as peroxisomal biogenesis defects. They're disorders where the peroxisomal enzymes and proteins are not imported correctly into the peroxisome. And you have a number of biochemical effects from this, including elevation of the very long-chain fatty acids, abnormal and decreased plasmalogen synthesis. And more recently, we've learned that this disruption actually affects the mitochondria, which are the energy-producing parts of the cells as well. And so what he looked at is this gene called ATAD1, which is a chaperone protein. So kind of think of it kind of like a chaperone to the prom, you know, that it brings something to another place and supervises kind of in a way, but isn't the main gene that's involved in the condition, because these conditions are usually associated with defects in the PEX genes. But this gene facilitates the removal of mislocalized proteins from the mitochondria. And so their hypothesis was that if you could relocate those back out of the mitochondria where they might be able to be used or integrated into some membranes that are left over from the empty peroxisomes, that might be helpful. So he presented some work in cell cultures of PEX1 and PEX3, which are two of the more common peroxisomal biogenesis defects or Zellweger spectrum disorders. And what he found was, this is a bit hard unless you know how to read these, but basically, the more blue it is, the more deficient. And you can see that when they added this ABCD, it's hard for you to see, but it's trending more and more towards normal, and that's the plasmalogen synthesis. So it did restore some plasmalogen synthesis. The very long chain fatty acid values decreased. And the other thing was here, this is evidence respiration is what mitochondria do to make energy, and you can see here the ADTA1, there's a significant increase in the energy output of the mitochondria. And so this was in a cell culture, and so now the next step is to try to increase the expression of this gene ATAD1 by using gene therapy in mutant mice to see if it has a clinical benefit for the mice and if it also replicates this improvement in the biochemistry. So I suspect that you'll hear about that second part at next year's meeting because it's sort of the next phase of his study. Okay, now this is a very busy slide. It actually looks like one of a poster. This was provided by Dr. Erica Maghrabi from the University Children's Hospital of Buzi. And it looks at sort of the functional characterization of one of the genes related to Aicardi-Goutieres syndrome, IFIH1. There are 9 genes that are involved in Aicardi-Goutieres syndrome, and this is a condition where in the spinal fluid there's extremely high levels of interferon. So all of these genes are involved in the synthesis and metabolism and regulation of interferon and its related inflammatory pathways. And so the purpose of this study was to try to characterize, well, how does this gene integrate with the other genes? What does it work on? And a lot of data was presented during this presentation. Which was not new information that we didn't previously know about this gene. And what they're doing now is they're enrolling some patients to see if regulation of this gene may be beneficial in treatment of AGS. And so this is the description of the current study where they've enrolled one patient with AGS with this gene defect and one healthy patient. And you can see what they are planning to do is take skin fibroblasts and then do all sorts of gene-related expression studies and what are called omics, we call lipidomics, where you look at all the different lipids, proteomics, what proteins are increased and decreased, and so on. And so they're going to further evaluate the role of this gene and how they might be able to develop treatments, at least for that form of AGS. Excuse me. Dr. Laura Adang from the Children's Hospital of Philadelphia presented a nice review of the recent advances in multiple sulfatase deficiency, looking at how to make the diagnosis, what are the different clinical phenotypes, and some potential treatments for this very rare condition. Now we think of, when we think of sulfatases, we often think, say, of aryl sulfatase, which is involved in metachromatic leukodystrophy, for example. But sulfatases actually catalyze multiple cellular reactions, and I think that there are 18 that are clinically significant sulfatases, so that create different medical conditions. And we've often thought that if you have multiple sulfatase deficiency, that all of those are affected equally, but that's not really the case, and that partly explains why individuals with that may have, they may look more like a patient who has metachromatic leukodystrophy with, say, some features of a mucopolysaccharide disorder, or they have different features that separate them from patients with metachromatic leukodystrophy. So she presented a bunch of data about this. And you can see that some of these sulfatases are not involved just in leukodystrophies or brain disorders, but they can also affect the heart, the lungs, the eyes, the spine, and the bones. And so distinguishing this disorder from others is important for the treatment of all of those other organs and monitoring for heart disease in particular, of course. They've looked at a number of biomarkers which can make it much easier to determine that it's this condition, for clinicians, for example, and how do they determine and make this diagnosis. They've found that some of these biomarkers, depending on how high they are and what's the relative value of the different ones, can indicate to some degree, well, what is the severity of the disease? What will be the progression of the disease? Like, at what rate might you expect that disease? And they're trying to look also at are any of those things modifiable in order to develop treatments for the disorder. They also have a patient-centered trial design where they're asking families with this condition, well, what's important to you? And this is something that I think Dr. Adang does very well. She has a number of programs where it's very patient-centered. What is your quality of life? How does the disorder affect the family, et cetera? And so she also has a study related to that that's ongoing. Yep, that's a bit dark, sorry. Dr. Jamie Fraser, I think some of you may have attended her wonderful presentation in The Patient, and she presented a very nice overview of this condition. I wonder if it lightens up a little bit. Let me see. Nope, it does not. Okay, sorry. The earliest hallmarks of this disease are prematurity or intrauterine growth retardation, so being small at the time of birth because of lack of growth in utero. Seizures usually occur within the first year of life. The majority of kids with this condition are actually diagnosed with cerebral palsy, and sometimes the term progressive cerebral palsy is used, which should always make you think maybe this could be a leukodystrophy or another neurological problem. They may be labeled as just developmental delay or developmental regression after normal development. The MRI at the very earliest time point may be normal, and so a repeat MRI would be important. And as you can see here in this patient, I hope you can see this, that you can see that there's sort of a diffuse abnormality here of the white matter, you can see here. And when white matter abnormalities, I always used to tell the residents that if a white matter abnormality, you could kind of fold it over and it's diffuse and it's sort of symmetric, you should always think of a genetic leukoencephalopathy or leukodystrophy rather than MS, which is more patchy. And start pursuing a diagnosis of a genetic leukodystrophy. But you can see on these ones on the left here, there are no cysts, and cysts are not present early on, which sometimes makes the diagnosis very difficult. Now, thankfully now with molecular testing, it may be included on a panel. And you can see here that later on the cyst evolved, and that made it much more obvious. The problem is that many of the companies that are doing testing, this gene is not included on it. And because it's a bit of a tricky gene that's sort of hidden inside of another gene, it is not always picked up, and so they have to look for it specifically. Males have a harder problem growing than females. Seizures worsen over time. They have movement disorders, including dystonia. Sometimes cysts will become so big that they'll cause blockage of the flow of the spinal fluid and need an intervention. Imaging should be performed if there's any change in clinical, like in any leukodystrophy. You know, if there's a sudden deterioration, an MRI may be needed. And there's a question of whether any surveillance is needed, because one would only probably treat a cyst if there was a symptom with it. Because there's always a risk to treating a cyst. Steroids in an acute situation will sometimes help. And chronically, there have not really been any clinical trials that have shown clear evidence of benefit, although a few things have been tried, as you can see. We also had the opportunity to have Dr. Walter Korschetz, who's from the NIH, talk to us about collaborations and grants that are available through the NIH. And the NINDS, which he is the director of, actually spent $11.87 billion in fiscal year 2023 on neuroscience research. And their goal is to seek fundamental knowledge about the brain and nervous system and try to reduce the burden of neurological disease through basic translational and clinical research. And they have a number of projects related to leukodystrophy that are currently funded through the NIH. And they also have NCATS, which is a consortia of there are 8 rare disease consortia, one of which is GLIA, which is the Global Leukodystrophy Initiative Clinical Trials Network. And that has 4 clinical research projects currently, 8 clinical trials, and 39, which is incredibly impressive, publications since its inception. And he also talked about a number of upcoming sort of granting possibilities that are for rare diseases that will be wonderful for our research community. Dr. Holly Rutherford joined us from Sheffield University. And she talked about a condition called RNA-SET2 deficiency leukodystrophy. The purpose of her study was to look at how one could potentially replace immune cells in the brain to treat this condition. The immune system in the brain is organized into a number of cells, and the microglia were the ones that were not working properly in this condition that were being targeted by this study. And the reason that they used zebrafish is because the mouse model, interestingly enough, does not have a deficiency of myelin. So in order to look at a clinical effect, they actually needed to use the zebrafish where they could look at myelination. This is a very small little tropical fish, and it's a tool that you've heard about already in this conference probably a number of times. They used a specific type of zebrafish which has a faulty gene for this RNA set 2 deficient leukodystrophy. And it develops impaired movement, which is tracked by swimming in a little pool and looking at the pattern of swimming, white matter lesions, and inflammation within the brain. And the way that they do that is they remove some bone marrow from the adult zebrafish, and then they tagged them with a green fluorescent protein. They then injected them into the bloodstream in a 2-day-old zebrafish, which is old enough in a zebrafish life, okay? And then they gave them a few days, and within a few days, the immune cells had already moved into the brain. And then they were able to look at the effects of that. And what they found after these transplants is that there was improved motor function, as you can see in the little swimming pool there. There was reduced inflammation in the brain. And this is the survival usually in weeks of a zebrafish. And you can see that when the ones that aren't transplanted, only 40% of them can survive to 4 years, and here 80% almost are survived at 4 weeks. Excuse me, not 4 years, 4 weeks. And so they felt that this would lead to a potential treatment, so now they'll move on to other models and see if they might be able to replicate these benefits in other models of this disease. Oops, there we go. Dr. Allison Bradbury is from Nationwide Children's Hospital, and she talked a lot about the AAV, or the adeno-associated virus gene replacement therapy that you've heard about also in this meeting, and how it's shown some promise for multiple leukodystrophies, including metachromatic leukodystrophy, ALD, Canavans, and Krabbe disease. And I mean, basically what you have is, with this, the way this works is that you have a gene defect, and so there's a deficiency or a lack of the protein. And so what you do is then you put the gene that you're interested in into this virus, and then it goes into the cell. And if you can get this to integrate, then the cell should start to make the protein, and you get a functional protein. That's the basic kind of premise of gene therapy in general. And so this is one of those, there we go. And so in Krabbe disease, they looked at this in Krabbe disease, and what they found is that doing hematic stem cell transplantation plus gene therapy together actually worked better in dogs than doing one or the other on their own. And part of the reason for that is that they were trying to target both the central nervous system disease, the leukodystrophy, and the peripheral nerve disease, which we know continues to progress often after hematic stem cell treatment alone. And so they've done this, and they have some preclinical trials in dogs, and now they're going on to do some additional studies with that. They also they've also done some work in vanishing white matter disease, where they've used a similar, where the gene defect is causing the loss of function. The mice with vanishing white matter die at a very young age if they're not treated. They have treated them by using injection of the AAV that contains the gene directly into the CSF spaces of the brain. And what they're trying to do is get it directly into these nerve cells and other glia cells in the brain to see if it will produce and so far they've had some mice where this has increased the myelin, increased mobility, and increased survival. So this is also an ongoing study. Our last speaker for the day was Dr. Florian Eichler, who many of you know, and he presented, I thought, a very clear overview of, well, what is gene therapy? And so, you know, on the left is again, this AAV-based gene therapy, where you have a targeted gene, right? You put it into the vector, and in his investigations, which are currently, there are some in clinical trials in humans, in Canavans and GM2, and this is a preclinical, they actually infuse it using an IV, so not directly into the brain, but IV delivery of this AAV-based in vivo gene therapy. For X-linked adrenoleukodystrophy and metachromatic leukodystrophy, there are already treatments that are commercially approved that uses what's called a lentivirus-based ex vivo gene therapy. And what you do with that is you take the patient's own bone marrow, you then use the viral particle with the targeted gene to kind of infect those cells, basically, and then you multiply them and you do a bone marrow transplant using the patient's own corrected cells, and that removes the risk of graft versus host disease, where, you know, usually if you have a stem cell or bone marrow transplant, it can attack the person because it may be different enough that it's attacking the person, causing rashes, et cetera. But you get around that using this technique. What we don't know, because lentiviruses are similar to HIV viruses and they stay forever, you know, could you have an increased risk of, say, lymphoma at some point in life or not? And we don't know that yet. The third thing he talked about was what's called antisense oligonucleotide gene therapy. That's currently in trial in Alexander disease. And the way that works is in Alexander, unlike the others where there's a deficiency, GFAP is increased. And so the goal is to decrease the amount of GFAP that's being produced so that there's less being deposited in the brain. And so to do that, what they do is they basically are trying to block GFAP from being made with this little antisense oligonucleotide. They inject those into the spinal fluid directly, and they have a pump as well where they can inject it repeatedly, and they're trying to use that currently for Alexander disease. So those were our scientific presentations.